All right, and welcome. Going to play a video. My name is Dr. Adam O'Brien, and I'm going to give a response to Bessel van der Kolk's um, brief thing on MDMA. So, PTSD, pervasiveness, and these types of clients. So, capturing what van der Kolk is saying in that this population is somehow separate from other clinical populations, of which severity, moderate to mild, um, would be ways that the diagnostics categorize them, and treatment history and stuff like that. Um, the moderate to severe cases of PTSD, in my clinical experience, um, are predominantly uh, what are people are living with. Um, the range in which the diagnostics come into play is really predicated upon and meaning like bipolar, depression. People will come in saying that they have these things. I've been diagnosed with that, but it's really a facet of dissociation. And I know that van der Kolk knows dissociation to the degree that he does, of which that's what I would like to engage with as a conversation. Especially around the topic of taking psychedelics that create um, dissociation at its core, type of dissociation, these types of things is what I'm interested in. Giving them medications that have not been shown to work very well. So there is a leader in the field who has wrote a paper, I believe it was about Prozac, saying that it doesn't really touch the PTSD clients. Now, the pervasiveness of PTSD, of which I argue is dissociation. If you look at the symptoms of PTSD, they are basically outlining dissociation and how the process happens, um, like to a T. The symptoms of PTSD are describing what dissociation is. And the dissociative effect, meaning like the things that trigger us into those types of situations, are going to be reminiscent about the past or about the dynamics of the relationship and stuff like that. The other thing I'll note is that the majority of these more complex cases are usually related to the attachment and developmental trauma that is different than PTSD, of which van der Kolk argues for. And I've made several videos asking him basically to not push for a diagnosis um, for developmental trauma disorder. Uh, we can justify even more so. The reason why is we can justify even more so treating normal as if it was a pathology. And based on his paper that I based my dissertation, a lot of it on, in his life's work, the crucial piece is missing that addiction piece. And he understands it, but I would like to ask about the pervasiveness of the relationship between dissociation and addiction if we are able to define the body as the psychological unconscious. that is like what a lot of clinicians are looking for other things for, to be able to help people get out of this misery. The problem is that they're addicted to the misery, not necessarily in a conscious choice, but when we define addiction as a unconscious choice, and define the unconscious as the body, and we understand conditioning in the body, and we understand conditioning as a facet of healing and how it has to happen, that tearing and repairing process, and what that does to people, and why people are looking for more advanced treatments or more medical things, is same reason why they're looking for addiction. They're looking for a gene for addiction, and that's just not going to be the case. The mindset of the system that MDMA is now going to be in said that we can create a non-addictive opiate. That in hindsight should say, wow, the intellect that thought that they could create a non-addictive opiate doesn't understand addiction. And that conditioning factor is often missed. And I would say that that is reminiscent of developmental trauma and attachment type of traumas. In the fact that they are repetitive type of things that people are in a loop on, and they are looking to their parents or the adults to be able to solve the problem that they are having. Now, this is not for everybody's case, but that is where you get the more moderate to severe cases, as I have seen. Um, with respect to individual cases, these are generalities. One of the major points that I would point to is that if you can induce a psychedelic state, meaning breath work, and or that positive dissociative experience with something like a drug, then people can start to rewrite their story. They get access to that more positive side of them. They're stuck in the negative. They can't use their other system. And Kolk motivated me through his book, The Body Keeps the Score, to look into neurofeedback. And when people have a neurofeedback established, they have a neutral in which they can go between the positive and the negative systems. What people do not need is more medication. The medication can reset them in a way, but they still need to have this grounding facet to it. Dysregulation is dissociation, and giving people a dissociative may bring them back. But from a recovery perspective, it doesn't do it. They're going to keep looking for more, and becoming addicted to therapy is a real thing, of which I know Kolk knows. Giving them as far as having, trauma resolution as a major point to trauma therapies, the ability to create conditions in which memory reconsolidation can give us the results of resolved traumatic memory. Um, we don't have to keep giving people drugs. They need to have that experience and be able to put it behind them. Now, most people come into this wanting that right away, but their body isn't regulated in the degree at which they can. So keep giving drugs, like, cautious about that. I'm sure there's more to the sentence. But the point being is that the drug isn't what heals people. It's the relationship to the drug, or to the provider, or to the methods that they use, or they find that along the way. So unless you're doing microdosing, which I don't think any study really has been doing about MDMA, they're looking to be able to have people have experiences in which they can resolve the memories, of which is memory reconsolidation, of which is a dual attention state that is better achieved if you have a neutral. Yeah, there's a wider range of understanding the diagnostics. When we understand addiction, you're playing with fire when you're playing with chemical um, chemical medicine and addiction. My point or case is that the drug is traumatic, of which the stronger the drug, the worse the impact of the trauma. You don't need those things unless you are not able to understand and or relate the importance of understanding dissociation, which is really understanding consciousness, what consciousness that you're talking to. When you start really looking at the nuances of the dissociative parts, and who's talking, what age are you talking to? It lowers the risk exponentially. That is our work. That's my work. Meeting area screening and assessment. I'd like to be able to offer that more to more people because it has changed my clients' lives. But if we work in a system that is still prescribing medications and cannot get the diagnostics right, and that dissociation is transdiagnostic, trauma is transdiagnostic, addiction is transdiagnostic, according to my dissertation, as a like start we don't have to be that cautious with these people. These people need to understand what it is that they're signing up for, and every one of them will reject doing it if they have an honest understanding of it, of which is what my work, I would say, does. They are not a major public health issue. There is a major issue with public health, of which is much more systemic, and whether you agree with it or not as far as a political movement, but make America healthy again is a rather interesting request or like challenge to the American people to find, like, are we healthy? Why aren't we healthy? What is the public emergency or crisis? I would say that they are less the people who have been injured by the system or who have tried to engage the system and have been let down time and time again due to systemic failures or bureaucratic, you know, incompetence. Um, um, they are not as much of the problem. Training is a major issue. Understanding is another major issue. The quantitative mindset is another major issue because you have to start to believe in the language that um, is different than what you are highlighting. Of which neurofeedback speaks a universal language of ones and zeros, a differential system. And what I have seen from my work, having done neurofeedback for the last 5 years, the longer people do it, the more they are likely to get that type of regulation that they need before they do the drug, before they do the reprocessing phases of things like EMDR or brain spotting or deep brain reorienting or progressive counting, or really anything that accesses memory reconsolidation. Treatment of mental illness. Is it an illness if we don't have the diagnostics correct? And if people can misdiagnose bipolar for dissociation or deep depression as dissociation, of which my work highlights how those things can easily be understood. Borderline personality. These things can all be understood when we understand positive pathology. And the positive pathology is somebody who would label this as mental illness. The disease concept coming from addiction is not accurate psychologically. We could do better. I have done better in explaining this in other places. Keep looking into my work if you're following this and watching this at all. Don't really need to study it more, because if the physical body is the psychological unconscious, you just need to listen to the psychological in order to treat it. I think treatment is the best way of diagnosing. Because if you are coming from a system that does not have an accurate definition of addiction, then you do not have pathology accurately defined, and you could be calling something that's mental illness. Actually, that is a solution, and actually that is the story of PTSD, is that it is really dissociation, and what it also is really, it is addiction, because the person is bonded to the traumatic experience that is the dissociative experience, of which uses the opioid system, which creates dependence and a dependent behavior. And that dependent behavior is a younger version of self trying to figure out how to survive in this age, in this day and time, with only the reference from your reference age. Which is a major problem, that these things are so expensive. And or the studies that you're doing, I don't know how much we need. I think we need to accept what the research is really saying. Hopefully my dissertation would be something that people would want to read, because I think it answers a lot of life's questions in a lot of different ways. It's something that people probably could read over and over again, because it has so much in it to be able to completely understand it. But you are assuming that these things are separate, that psychology and medical are separate. When the body is the unconscious, it levels the playing field. We do not need to do necessarily more studies on the impact of stress on the body. This is a stress. The drug is a stress. The lifestyle is a stress. The body also needs to be building resilience against that stress, of which, this is, again, as I got sidetracked, the story of PTSD is labeling dissociation as an abnormal response to an abnormal event, of which 20 years later it becomes the solution that has to be. It is a normal response to a normal event, and we have normal being the norm. Trauma from the ACE study is the norm, and we are saying that people who can't get back to baseline are mentally ill, what about the system's role in not being able to get back to baseline? Um, and the the system represented in our food choices, in our access to care choices, the level of understanding that the clinicians must have. um, Psychiatry cannot accept that these things are separate when the body is the unconscious. I asked a medical doctor, my neighbor growing up, what they thought of that. He said, "We're saying the same thing." Who's a medical doctor? Um, I said we're kind of saying the same thing, and I'm like, yeah, we may be saying the same thing, but you guys are territorial over it. Psychiatry should be able to see how the body is manifesting the illness that is when dissociation becomes addicting. And then you treat addiction. Gabor Mate talks about it pretty plainly, that there isn't enough understanding within the medical community for addiction because they maybe have a couple lectures about it. From a person as a person in recovery, I don't know if people who don't understand addiction and or think that these things are separate or that you can separate them are the ones that should be in charge of them and or studying them. We have enough research. We have enough qualitative research. This quantitative research, all the numbers that people can spew out, we've already done the research. Stress affects the body. Why not work on making these things more accessible with proper education and being able to disseminate it cheaply to all people? My other example, Dr. Jordan Peterson, in testifying in Congress relatively recently, gave a wonderful way of saying, hey, if we had somebody in charge of like saying, like, here's an example, if everybody were to go on this diet, we could, and here's how you do it. It's perfectly safe, and a lot of your mental health symptoms will go down. I'm all for working the solution. Jordan Peterson, great job. The major advance then would be neurofeedback in meditation, and I would argue cannabis as a way of being able to help people find their regulation point who can't do neurofeedback. That's what I do, we do. No, yes, okay. I don't know if we need to study because we already have lived experience. We can go to another therapy like EMDR and be able to see what have you done to be able to support these people. Though, like as an EMDR trainer, there is a learned lesson here that we need to be honest about. And from a training perspective, we have to be able to teach people dissociation before they can understand trauma, because they are one and the same and you cannot separate them. Where I was trained in EMDR, Dr. Ricky Greenwald, he created a model that helped, the fairy tale model that helped show how clinicians need to become trauma therapists, trauma informed about the pacing of these things. And that model helps us be able to learn, but it doesn't necessarily help the assessment and screening process of which mine does. And then a similar path with EMDR, the 8 phases of that, with these clients that are histrionic and or borderline, it is about understanding the dissociative features in which our dissociative parts and understanding that and making that acceptable. The stigma of mental health and the basis of mental health is going to be dissociation. When you understand that, you understand, what mental health is and what it isn't. And then we enter into positive pathology, of which is where I'm at with the work. I can talk about trauma all day, and recognize that we are still in the shadows. We are still working within a system that says that this is an abnormal response to an abnormal event. It does not diagnose and shouldn't developmental trauma and attachment traumas because they are the norm. All traumas apparently are the norm. So why are we pretending as if they are abnormal? But I'm glad that somebody's having this conversation. And Vander Kolk is out there towards the end of his, career, as he says here. And I think that the next wave has to be an honest appraisal of the systems and how they are contributing to a prolonged state of stress at the to their benefit, but at the cost of the people who can't afford these medications and or these types of therapies, or who can and don't get what they need because the system does not have accurate definitions of the words that they claim to have. For example, unconscious being the body answers a lot of questions. My definition of addiction as a trauma-related response and conditioning answers those quite beautifully. And keep following our work, because this needs to be advocated for. And I don't think necessarily that Vander Kolk would disagree with anything I would say. I don't know. Usually it's about how we say it. And my hope is that it is helpful for people to understand that the screening and assessment and proper understanding, and I mean moral and humane understanding of what dissociation really is and what it isn't. It is not pathology. It is prolonged pathology because it was not able to come back to baseline, because the world was not able to be there to help the people regulate. They're not clingy. They are real about, or their reenactment. You can understand it in that way, and clients can understand it in that way, and they may not accept it, but until they accept it, then that process continues. So hope this is helpful.